Assalamu alaikum everyone, and welcome to today's lecture. Today we will be talking about the last of the three studies that are considered to be observational studies. And this is going to be the highest in the hierarchy of evidence among the three that we have talked about, and it's going to be about cohort study design. Okay, so let's get started. So the objectives that we will be covering for today's lecture is, first, we will talk about what is a cohort study design, how to conduct it, and we'll use some diagrams to help us understand it better. And then we will talk about how do we select our study population in this type of studies, and what are the sources of exposure identification. And then we will try to talk a little bit about the advantages and the disadvantages of this type of study designs compared to the other two that we have already mentioned in the previous lectures. And then we also would like to understand what is the outcome measure that we use usually to report results in cohort type of studies. If we come to look at this diagram summarizes to us a cohort study design. So if we can try to trace, so if you can look at the left side of the screen, here it says the beginning of the study. So we are moving in this direction in our study. So you will have study participants, and this is the present where we are standing now, where we are starting our study. And the study population or the study participant will have risk factors present, and of course these risk factors you will be selecting based on your risk factors of interest that you want to study. And you will going to divide this study participants into two groups. The first group is the exposed group, and the other, and also it's called the index group, as we're going to see in a bit. And the other group is called the not exposed group, or the referent or the comparison group. So remember here, or notice at this stage, the disease is not yet present. So we are looking only at their exposure. So somehow it is similar to experimental study, where the difference is that in cohort studies, because it's observational, you're just observing what people are doing. So the exposure is being assigned depending on the people's own behavior, compared to experimental studies where it is the researcher who assigns the exposure to two groups. So as we're going to see also in the coming lecture about experimental study. Here, people, for example, if you're looking at the effect of smoking, so smoking is going to be your exposure, and non-smokers will be another group of non-exposure. And because it's not ethical to ask a group of people to smoke and other group not to, in order just for you to see the effects of smoking, knowing that it is harmful for these people. So you just go and choose people who opted to smoke, because in real life, people choose to do different or to follow different health styles that might be healthy or might not be healthy. And it is because it was their choice. You can take advantage of that ethically to conduct such studies like cohort studies, where you follow them from their exposure up to whether they are going to develop the outcome of interest or not. So what you do here is that after you have divided your participants into exposed and non-exposed. Let's say the exposed are smokers and the non-exposed are non-smokers. So all of them are non-smokers. And then you follow them up in time and you count each one who would develop the outcome of interest during this period. Okay, here also among the not exposed, you might also get people who develop the outcome of interest, and hopefully they won't be as much as those who develop it among the exposed group. So you will measure how many of them who are exposed has developed the outcome compared to those who are also exposed but did not develop the outcome. Let's say, for example, 2/3 of them developed it and 1/3 did not develop it. Okay, and then you come and compare it to your other group. Among the not exposed group, how many have developed still the outcome of interest, because some of them will still develop it although they are not exposed, compared to those who did not develop the outcome. Let's say who developed the outcome are just maybe, let's say, 1/5 of all those who are unexposed, and the rest, for example, did not develop it. The majority did not develop it. So you come and you do your calculations, and this is, for example, the future where we are going to in cohort study, and that is the end of the study where you're looking at the outcome. If you remember what we have done in case control instead, in case control study we have started from this point of diseased and not diseased compared to exposed and non-exposed, and then we were going back in time and asking the diseased people how many of them were exposed and how many of them were not exposed, and we did the same with those who are not diseased, and we asked them how many of them were exposed and how many of them were not exposed. So can you see how it is the reverse of what we have talked about in case control study, and this is the cohort study. I hope this is clear. So how do we select our study population, since we are starting with people who are not diseased? So we are selecting them based on their exposure status in this case, right, in cohort study. So we have to identify those who are exposed, and those are also called index group, and our unexposed group from the population will be called as the referent or the comparison group. And then what we do is that we follow them up in time and we wait for the outcome of interest to occur among both groups, and we will be documenting that occurrence until the end of the study. So you identify later who are the subjects that got the disease among the exposed group and how many of those got also the disease of interest among those who are unexposed. But you have to remember that the key comparison where you start with in cohort study is between the exposed and the non-exposed, compared to case control study where the comparison is among the diseased compared to the non-diseased. Can you see how it is the reverse? So this is cohort study. Let's look at this slide here, which also gives us a better probably visualization of the cohort study design. So if you can look at this, it's in a diagram. It shows two groups here. The exposed groups are smokers and the unexposed groups are non-smokers. Then we followed them up in time, and our outcome of interest was lung cancer. How many of those who were smokers developed lung cancer during the follow-up period among the exposed group, and how many also developed lung cancer but were among the unexposed group. And you can see, for example, here that about 4 individuals, for example, have developed it among those who were smokers compared to a less number. And that's what you expect, of course, if your hypothesis is true and that there is a relation or an association between smoking and lung cancer, for example. All right. Now, because in case control study, we start our 2 groups, one group to be diseased and the other group non-diseased. So we were very focusing on how to define a disease. If you remember the example that we gave last lecture about we are interested about people having a myocardial infarction or heart attack, and what is the criteria to say that, okay, this person is a true case and it should be among my cases, and this person is not a true case and should be among my non-diseased. It is the similar thing that we need also to focus now about the exposure. We cannot take the exposure status lightly, and we have to think thoroughly about who will be exposed, who will be among the exposed group and who will be among the non-exposed group. So you have to have a definition. And because exposure is unlike disease, whether you have the disease or no, right? Whether it is acute or chronic depends on what you're looking at. But the exposure, it has the characteristic of variation over time, especially if you are following people over time. People change their behavior and they are not the same. A person who smokes today might decide to quit. A person who used to be a smoker in the past might not be currently smoking. A person who smokes 1 cigarette a day, I would assume that it will be different than a person who smokes 1 pack a day or 2 packs a day. So you have to think carefully, first of all, who is considered to be exposed in your cohort study. Is anyone who smoked in the past will be considered still exposed to smoking, no matter if he is not continuing to do it over the study period, or you just need those who are still smoking over the follow-up period until the outcome emerges or appears. So you have to be very clear, and then you have to give also more specification to the exposure, given that it can change over time. Like the onset, does it matter who will be in your exposed group if it's a smoking? Do you want people who smoked since they are teens to be among your exposed group, or it doesn't matter even if they have started like 1 year or 1 week before you commence your study will be considered in your exposed group? What about the dose? All right, as we said, does it matter if they smoke few cigarettes a day compared to other people who smoke a pack or 2 a day? They all will be grouped together as exposed. What about the duration? Does it matter if they smoked in the past and stopped? You will include them as previous exposure, or those who are smoking currently, or those who will be smoking but will stop in the middle of your follow-up period will still be considered as exposed and won't be removed from your exposure group. And the frequency. For example, somebody who doesn't smoke every day compared to somebody who smokes every day. Does it matter at all for your study? And how consistent are they? Again, how consistent they might stop few months or few weeks and they go back to it, compared to others who do it, for example, stopping for a couple of days and go back to it, or they're just smokers in the weekend. Or does it matter if they are smoking pipe or they're smoking cigarettes, or they smoking cigars, or they all can be grouped together at similar risk. So that's what you can see sometimes people do in cohort studies, that they group their exposed group. They are not all being put in one group. For example, ex-smokers and current smokers, or there will be mild, moderate, and heavy smokers, 3 different groups. And the benefit of doing so in defining your exposure, in grouping your individuals, that it allows you to see if there is any what we call as dose effect relationship. It allows you to see whether those who smoke severely, given a certain definition of what you mean severely, are actually at a higher risk than those who smoke mildly, compared to putting all of them in one group. And that differentiation, or that difference between the different categories, will be masked or will be obscured, and you won't be able to give that precise conclusion. And that's what people also do with other diseases, like for certain types of cancer, for example, not cancer, let's say about, because we're talking about exposure here, for example, different diets, and they can also do that grouping. And you can think if it applies also about different types, for example, radiation, or of exposure to certain chemicals in the workplace, or others. So these all should be taken into account when you define your exposed group compared to the non-exposed group. And sometimes in some research, it is sometimes very difficult if you want to take a comparison group to your exposed group, which is the unexposed. Sometimes it's very difficult to find no exposure at all. So you might consider the unexposed group to have a very low, and again you have to define what do you mean a very low exposure, compared to the exposed group with high exposure. For example, you are interested to carry a research about asbestos exposure, which is a chemical in a factory, and its relation to a certain type of, let's say again, lung cancer. And you want to get, since you are taking, for example, factory workers, because they are more, for a reason or another, exposed to that asbestos chemical, and you want the unexposed group not to be from the general population, because you think the general population do not match factory workers, and you want to take it from another factory which also deals with chemicals. And it happened that they also have got small level of asbestos in their exposure in their workplace. So, but it is not as much as the exposed group, where it is a factory that deals with products that are heavily contaminated with asbestos. So you can choose the other factory as non-exposed, given that the exposure is very low, and you can do the comparison. So that also you might come across if you read about some of the cohort studies, and that also doable. All right. What are the sources of exposure identification? Again, the best thing is, again, to go through hospital records. Now, in hospital records, usually you will hear terms like retrospective and prospective cohort studies. The most classical one is the prospective cohort. Yeah. And prospective means you are going forward in time. So you are taking people who are exposed, non-exposed, and you wait like for whatever time you need. Some infectious diseases you wait for a few hours or days or weeks to see the outcome. Some chronic diseases you wait longer than that. Some tumor cases, if you are interested to look at outcome of cancer, we know that cancer takes long time from the exposure until it occurs, so that will be even longer. So you will wait, and you will be collecting everyone who gets the outcome of interest among the two groups, the exposed and then exposed, until the end of the study. The faster way to do it is to do it retrospectively. Retrospectively, you're looking it behind in time. So for example, what you do is that you go to health records, you look at people with cancer and without cancer, yeah, and then you are going back in time, and you're looking at what physicians have recorded about the risk factors that you are interested in. For example, family history of cancer, smoking, and so on. Now, some people will say this is a case control study. Well, it is not considered case control study, because in case control study, you're going to take disease and non-disease, and then you're going to ask them individually about risk factors. You will ask them, have you done this? Have you done this? In retrospective, we are saying that it mimics like if the physicians are actually, among their course of seeing patients who are exposed and unexposed, are collecting data without knowing who will get the disease and who will not get the disease. And because these patients are following up in the same hospital, you will keep recording data on risk factors without you knowing actually that you are doing so. And then if they get the disease, you will label them. If they don't get the disease, they will not be labeled. And then if a researcher comes later in life and will be interested to look at the effect of those documented already ahead of time without purpose of conducting a study to look at the relation between the exposure and the disease, you will go back and take advantage of that documentation and will carry it. It's a cohort study, but you are looking at retrospectively. You are looking at back at time. It is a bit complex to grasp the idea, but the only drawback and disadvantage of looking at hospital records is that you might be interested about certain exposures, and it happens that the physicians who were documenting, like doing their job and documenting the different risk factors for the sake of follow-up of other issues in this person, before the issue of outcome of interest appears, that you are interested in as a researcher coming later in life, might not ask about all the exposures that you are looking at with the details that you want to have. So that's always will have something missing information, where you say, okay, I was interested in family history, but not all the physicians were asking about family history of malignancies in general in those patients during their lifetime of follow-up. So you will find many of the things that you want to consider as exposures missing, or not complete, or not detailed, like smoking or alcohol behavior. You want to know exactly the amount and the frequency and the duration and so on, and this will not be documented, basically because the physician who were looking at these patients did not put in mind that this will be used for research, so he was collecting it generally. So that is the drawback of health records. So that's why they will go back to these patients, and they will need to do further tests to collect data and information on exposure, like mainly questionnaires. But for other research that are more properly conducted prospectively, cohort studies that are conducted prospectively forward in time, you will do a lot of other tests to get more accurate and valid information on their exposure status. Like, for example, in asbestos, you cannot ask only people who are exposed to asbestos and those who are unexposed, how much of exposure do you think you are receiving. So to know that, you have to do certain, for example, blood tests or hair and nail testing to see how much they accumulated as exposure to these metals, or do urine tests, or you go to the environment where they're working and get samples from different objects and measure it, and you assume that is the amount that they're exposed to get it accurately in numbers. And there are different other sources that you can think about. Of course, these are more expensive. The good thing about hospital records, that it's easy accessible, cheaper, faster, because you're doing it backward in time. But if you decide to do it properly, prospectively, so you get all the information that you need, all the details information, and accurate from the beginning among the exposed and the unexposed group. This is of course more accurate, but it's more expensive, more time consuming, and needs more resources and money, because you have to go and get all these samples and run it and get the numbers and so on. Okay, so this is a brief explanation of the sources of exposure in cohort studies. And by the way, what does the meaning of cohort? Cohort is a group of people with similar characteristics, and the actually the word cohort came from a Latin word which means soldiers. And because you soldiers, usually if you see how they march all together as one unit, so very similar to each other. And this is how similar you want the exposed group to be compared to the unexposed group. They are similar in everything except the presence of exposure among the exposed group and the absence of the exposure in the unexposed group. And it is now cohort means like a cohort of group of people who share the same characteristics. It could be the same age group, could be same living in the same city, could be having the same behavior of all of them being smokers, or having the same exposure, being all females exposed to radiation. And these common characteristics what makes them a cohort. Like for example, you are medical students, you are considered a cohort. You all started medical school in certain year, and you are taking all the similar subjects and modules to graduate at the end as MD doctors. So you are considered a cohort. So this is the name, where the name cohort came from. And this is something I should have also mentioned earlier on. What about the case identification? Case means the outcome, right? Because again, if you are following up people who are exposed and unexposed, and then you are waiting for them to develop the outcome of interest during the study period until the end of it, right? So how do you define who developed the cases compared not those who did not develop it? Again, to consider the case, it has to match all the criteria for case identification. If you're looking at lung cancer, you have to have not only people who are symptomatic for lung cancer, but also who have got different types of imaging that matches lung cancer. And it might be also until the very definitive diagnosis of lung cancer, which is only by, for example, a biopsy that confirms it, or confirms that it's not any benign, but it is the malignant one that you are looking at, for example. And where to get that information from? Again, hospital records is a common place to get cases. As we said, sick people usually they end up in the hospital. So of course you will be following your exposed group until they fall ill, and they will go to the hospital, and you will see if they are matching the ones that you are following them up, who developed the disease in the catchment area that you are looking at. Other sources for disease we have mentioned also in case control study could be cancer registries, if you're interested in cancer. So that's a special place where they record all people who develop cancer diagnosis for sure, and you can check which cancer you're interested in and target those. If you're interested in birth defects, for example, among group of pregnant women, if you're following them certain behavior or certain medication, being exposed to smoking, alcohol drinking, taking certain medication, and you're following them up on time during 9 months, and see how many of those who are exposed compared to those who are unexposed will give give birth to babies with certain birth defects, for example. And by the way, pregnancy is a good population, pregnant women, a good population to conduct cohort studies on, and that's what I have done personally for my PhD, because it's cohort study, it's still high in the hierarchy of evidence, and you know that everything what happens during pregnancy has usually to happen during the 9 months period, where they, you can say, like cook or bake the babies in their wombs. So it is a short period, 9 months, but also can yield very valid information because it is considered still cohort study if you know exactly what you are looking at as exposure and what you are interested in as an outcome. So for your future research, you might want to consider this group of population for cohort study. Okay. If we talk about some of the strengths of cohort study, now we have to think about it as a reverse of case control study. So there are some of the things that were strength for case control or weakness for case control. It is a weakness for case control study, but for a cohort study, because you are doing it from the other end, it is considered a strength. For example, rare exposure. Rare exposure, when we talked about case control study, we said you don't want to start with cases and controls and then you look for rare exposures. You might not find it at all, or you might find it very sparse. So anything rare, it is good to capture it from the beginning. Go, take the effort and time to look for it and start with it and move forward. So if rare exposure, that is a good thing to do for cohort study, because in cohort study you start with the exposure. You don't look for it backward in time like in case control study. So because you are starting with it, you can go and try hard to find it and compose a group of those with rare exposure as exposed and another group as non-exposed and follow up them in time and see if the outcome of interest will happen or no. So it is considered a strength here. Rare exposure is a strength for cohort study. And it is also efficient for diseases with short induction period. Yeah. And this is the example I gave about pregnancy, for example. Pregnancy is over 9 months. It's not very short, but not very long, but still it's a good period of time to look at different things that you can think about, to look at it, and it is still a cohort study. Nobody can argue with you that it is not a cohort study, so it is efficient. And it provides information on large number of possible diseases and can also measure the change in the exposure on the outcome. Because people, when they do cohort studies, and most cohort studies take a lot of time and it is expensive for follow-up for the outcome, you can choose to look at more than one outcome. So you look at different things in one study. For example, Framingham study. Framingham is a big heart study that were conducted on different people that looked at different exposures and different outcomes. And most of the information that we know nowadays about cardiovascular risk factors and cardiovascular disease actually came from this Framingham study. We will talk more about it when we talk again about details of cohort study in research methodology in the coming semesters. But for now, it's just to mention briefly. For example, they took a group of exposed people who were exposed to different things. It is not necessary that always you look at one exposure and one outcome. Of course, if you do that, you will be more focused and it's correct. But sometimes people, they want to take advantage. Since I'm following a group of people over time, I might also want to take advantage of all the costs and time that it will consume and look at different exposures and different outcomes. And that is of course a very good thing to do if you can do it accurate enough. So in that Framingham study, they looked at smoking, they looked at cholesterol level, they looked at having hypertension, diabetes, obesity, being male and being certain age group, and the effect of all these risk factors on different heart diseases, including heart failure, having a myocardial infarction, having arthritis, which is another problem in the cardiovascular system, and so on. And they were successful to draw, because they took also a big number of exposed compared to unexposed groups, so the sample size was also very huge in these studies, and it took decades. And you can imagine that no one researcher sometimes can continue conducting the study for like 30-40 years, and they will be handing over to a different group of researchers to carry on. So you can see how huge and difficult sometimes cohort study can be. And also you can, it says you can measure the change in exposure. For example, those who were smoking at the beginning and stopped smoking can still be in your study, but you have to document all this change in exposure. As we said, exposure is something changeable over time. People don't behave the same over the years, and you can quantify and stratify, and or we can say classify those who are exposed to different levels and check that difference, what it has on the impact of the outcome. And they were able to get different dose effect correlations from these studies. Temporality here is well established. If you remember temporality, because you are starting with the exposure and you are sure that the outcome of interest was not present by the time of the study, then you can making an association, correlation, and therefore causation, and relating the outcome to the risk factors is possible in cohort study. Okay, if we come to look at the limitations instead, it will not be efficient for rare diseases. You can see how we are just talking about the reverse here. In case control study, we said it is actually better to do it for rare diseases because you can capture the disease from the beginning, since you are starting from the disease status. But in cohort study, because we are starting with exposed and unexposed, it won't be good for rare diseases. You might wait so long for nothing to appear at the end because it is very rare. So it is effortless study design to conduct for rare diseases. Okay, for diseases with very long follow-ups, like for cancers and so on, it is a limitation because you might need a long time to wait for cancers. Although some cancers are common, but they take a long latent period from the time of exposure until it occurs, and that you might not have all the resources to conduct it that long. It is expensive, especially as we said, if you want to do it properly, not retrospectively but prospectively, and you do the collection of exposure. And sometimes some exposures you cannot just collect it by questioning individuals. You have to take tests and run tests, and that might be also expensive. It is very vulnerable to a bias because of loss of follow-up. As we said, as people change their behavior over time, people also are not easy to be followed up over years. People move around. We will not talk about death, because death can be tackled or can be analyzed in a certain way in cohort study. But other things like people, you might lose their contact, they might travel out of the area, they might change the place they live, they might decide not longer to be followed up by you, because some studies where you need every 2 years to go and check on your exposed and unexposed group, to check on their behavior, to check blood levels of certain exposure status and so on. It is not one-off time that you take the data of exposure and then you just wait all over the time, over the years, without checking your exposure status or change in exposure status. So you have to have them approachable, these participants in both groups, over the years until the outcome of interest. And you might not always get the luxury of doing that. People, you might lose them and they just disappear and you cannot contact them anymore, so that will affect your study. And especially if that loss of follow-up happened in one group more than the other, like among the exposed more than the unexposed, then it will affect your study tremendously, and it will introduce something that we call bias, as we're going to talk more about it in the coming lectures. And there is another thing that is called the healthy workers effect, is considered also a limitation in cohort study. What do we mean by healthy workers effect? For example, many cohort studies, the big ones, the successful ones, because you need to follow up, as we said, people, and you want to minimize the loss of follow-up. So people thought it is good to capture people who are in workplace, because you can see that we are bound to our workplace for years قبل ما نطلع التقاعد, and before we retire, right? And we are more likely not to change our jobs for years, and we are stuck with it. So people said we will go to people who are working in hospitals, like nurses, and that will be our exposed group. And actually there is a big study also on women health that included a number of nurses in one hospital as compared to another hospital, and they looked also at different risk factors and outcomes of certain women reproductive tumors like breast cancer, uterine cancer, ovarian cancer, and so on. And why they chose nurses? Because they said they are more professional, they're educated, they will be easy to reach, and they will be easier to respond to questionnaires and so on, and better response rate. And if we follow them over time, they're more likely to be in their jobs for 20-25 years in the same place, so we will minimize the follow-up. But what is the problem here? If we are considering, for example, our exposed group to be nurses compared to our unexposed group, where we will consider, for example, maybe we'll take people who are, because usually sometimes you give less attention to the unexposed compared to the exposed, and you will try to consider the unexposed to be from the general population. They say it is not that the loss of follow-up might be more among the unexposed group in this case, because general population, it's easier to lose them compared to people who are bound and tied to their profession. But they say also how different are nurses in their health would be, or people who are in the workplace, whether it is a factory, whether they are nurses, whether they are doctors, where there are teachers, for example, compared to general population who are not workers. People in epidemiology thought always that people who are working or in the workforce are always somehow healthier to fit their jobs compared to the general population in their own characteristic and in their behavior. And that is something natural for them to be in. Like, even if you think about policemen or soldiers, they are most likely non-smokers, non-drinkers, they are more active, and because they're in better jobs, so they are financially more secured, they might also make healthier choices in their for their food and their diet compared to the general population. So this what they came up with as a limitation called healthy workers effect. Okay, the workers, if we take them for reasons of not to lose the follow-up, they might be actually a little bit different in their characteristic and in their health status compared to the general population, who we will consider them as our unexposed group. And this should not be the case, because we said that the exposed and unexposed should be very similar, with the only difference to be the exposure status. Okay, I hope this is clear. So what is the outcome measure that we use normally in cohort study? If you don't remember anything in cohort study, just remember that the outcome of measure from cohort study is the incidence compared to prevalent cases. We said in cross-sectional studies is the best one because we are doing everything at one point of time. The only thing that we can report is prevalent. People who are already living with that outcome of interest that we are looking at, okay, among the population that we are interested in. But in cohort study, because you are following up people in time and waiting for the outcome to occur. So these outcomes or these diseases are not prevalent. There are not people living with them over the period of the study. They are instead newly getting diagnosed with it or developing it over the period of time. And this, if you can capture the number of newly diagnosed individuals among a certain group, whether at risk or exposed or unexposed, and you check how many of them will develop it over, for example, 10 or 20 years, depends what is your definition of the time period that you're looking at. These new cases are called incident cases, and this is typically done in cohort study, where that is the main thing that you are looking at. So incidence is calculated as the number of, and these are the terms that you have to pay attention, new events or new cases or new outcomes or cases of the disease, and it is being divided by the total number of individuals in the population who are at risk at a specific period of time. And this, we said, it is the period of you conducting your cohort study, and everyone who would develop it, these are considered all new cases that emerge only during this time. And they emerged from where? They emerged from a pool of individuals who were at risk whether as being exposed, or another pool of low risk of exposure who are the unexposed. Okay, now you have to excuse me trying to write with the highlighter. And you are also checking the incidence among this other group. Okay, and you can compare between the incidence rate among the two groups, and we will give an example of that. But here there are two criteria to consider an incident case as an incident case. First, they should be free of that outcome at the beginning of the study period. As we said here, at the beginning of the study period, none of them have still the disease of outcome. The only thing, either for these people to be exposed or unexposed. And then the outcome, the development of the disease will happen only during this study period. But at the beginning, no one has it, because if they have it from the beginning, they are called prevalent case. They are already living with it. Okay? And the second thing, they should have the potential to develop that outcome of interest during the study period. What does this mean? They have to have the potential. Otherwise, you cannot measure the incident case. For example, if I'm doing a group of exposed to cigarette smoking and a group who are non-smokers, I should be looking at diseases that, with the best knowledge that we have, are more likely to be related to this risk factor. Okay, for example, I cannot start with a group of, let's say, people who exercise and people who don't exercise. For example, women who exercise and women who are not exercising. And then I'm looking for certain birth defects like spina bifida among those. Let's say I'm taking pregnant women who exercise and pregnant women who don't exercise as my non-exposed group, and then I'm following them during their pregnancy and waiting to look at an outcome of spina bifida among those who exercises compared to those who do not exercise. With the best knowledge, we know that spina bifida is related mainly to intake of folic acid and probably certain elements in the food, and not about the physical activity of pregnant women. So you cannot measure and wait for the incidence among people who are not at risk of developing it from the beginning. Okay, so this is what it means, that they have to have the potential of having the outcome of interest among the population at risk during the time period. So I have to look at the right things among the right what I think with the best knowledge, the right risk at the time of conducting the study. How do you calculate the incidence? Is very simple. It is the number of persons who develop, and this is the thing, who develop the disease only during the specific period of the study and not having it at the beginning of the study. And you divide that number of people who have developed it over the number of persons who are at risk at the baseline. For example, here you did a cohort study to measure the incidence of breast cancer among women exposed to radiation compared to those who did not been exposed to radiation. So the exposure status is women with radiation compared to women without risk of radiation. And you consider to take equal groups, 200 in each group. Among the 200 who were exposed to radiation, 66 of these women developed breast cancer over the study period, which lasted for 30 years of follow-up. So they only developed that. They were new cases developed over the 30 years. At the beginning of the study, breast cancer was not present among them. And that compared to only 10 women among those 200 who were not exposed. So what is the incidence of breast cancer among exposed compared to the unexposed? So simply, I have repeated the question here. So the incidence of breast cancer among the exposed group would be 66 over 200 times 100, and that gives you 33% incidence of new cases. And the incidence of breast cancer among the unexposed, sorry, I will correct it here. Among the unexposed is 10 over 200 times 100, and that is only 5%. And you can see that how the incidence is much higher of the outcome among the exposed group compared to the unexposed group. And that is a simple way of reporting your outcome measure in a cohort study. Of course, there are other more sophisticated way where you take into account different things to report different measures of outcome in cohort study, and these are for you just to know the terms. Odds ratio, the one that we have mentioned in case control study, can also be used in the cohort study to report your findings, but there is also something called relative risk, and there is something called risk difference. These are also typical to be used to report your results of cohort study, which you will come to know more about the details of calculating it in the coming semesters when we come to talk more advanced about cohort study. But for this level of this semester, all what you need to know is that incidence is the measure of outcome, the primary or the first level of outcome measure that you can report from your cohort study, and to know what does it mean, how it is different from prevalent cases, and how it is calculated. Okay, this is required from you. And these terms of other outcome measures, just to know them by name. No need to worry about how to calculate them until in the coming semesters. I hope this is clear. This is all about cohort study for today. And I'll be meeting up with you on Thursday's tutorial. So the tutorial material should be up there on Moodle for you to go through and prepare it for our lecture on Thursday. Now, I have heard that there are some issues with Google Meet not admitting more than 100 people. We are trying to check with our CET department about that issue. Just in case if it persists, I think we will continue doing it as Google Meet, because we had very good experience. And in both times, actually, we no more than 115 students maximum were at the session. So for those who will not be able to to join because of the new limit of 100 students. The lecture or the tutorial will be recorded as usual, and the recording will be sent to you all, because it's our last tutorial and we just want to get through with it. All right, thank you very much, and bye bye for today.